I'd like to invite our next speaker, Vineet Sehgal from Delhi, to give us a talk on the importance of ocular blood flow and OCTA.
Thank you, sir. So first of can I have my slides, please? So first of all, I thank the scientific committee who have given me this opportunity to be on the dais, and I would be talking about the OBF and the OCT angiography. So we have lot of things with us. We have HVF, OCT, gonioscopy, disc photography, UBM, and now we have color Doppler imaging as well as we have OCT angiography. So whether they have added to our diagnosis or it has added to our confusion, we still do not know. So my presentation would be in two parts. So first part, I would be talking about the color Doppler imaging, and the second one, I would be talking about the OCT angiography. Before I start my presentation, a brief outlook of what the ocular blood flow is. So the main artery is the internal carotid artery that gives rise to ophthalmic artery, and we have the short posterior ciliary arteries as well as the central retinal artery, which basically form the blood flow to the optic nerve head. So where OBF analysis may have a role. Three roles that is there. First is in the patients of glaucoma, those who are normal tension glaucoma, or the patients of primary open angle glaucoma where there is a progression even on normal intraocular pressure. Second is the patients with ocular ischemia, and third is the vessel occlusion. So my favorite is detecting the underlying undiagnosed systemic comorbidities in the patients with ocular history. I would just show you two cases. So what is the protocol? The patients come to us, they are diagnosed as either POAG or NTG. We go for a 24-hour BP monitoring, and then we consider them for the OBF study, and then we complete the triangle with the cardiologist. So it is a cardiologist, radiologist, and ophthalmologist who are working in tandem. So first talking about the color Doppler imaging, we all know it's a non-invasive method. What we measure the ophthalmic artery, central retinal artery, and the short posterior ciliary arteries. We measure some parameters like peak systolic velocity, end diastolic velocity, and resistive index. So that is how the radiologist is doing the color Doppler imaging. Basically, it's my learning which I am doing for last 8 years. I have done it for almost all type of patients, trying to get some normative data, trying to get some baseline. So this is the report that we give to the patient. And as you can see below, we always give as impression what the radiologist thinks when he is doing the color Doppler imaging about the patient. And whenever we do a ocular Doppler, we also do a carotid Doppler. So we have different waveforms for the ophthalmic artery. Here, as you can see in the ophthalmic artery, there is a systolic peak, dichrotic notch, and a relatively little flow in diastole. Different in the patients with central retinal artery, where there is a rounded systolic peak, and different in the short posterior ciliary artery, where they have a blunt systolic peak and a low to moderate flow in the diastole. So two cases I would be talking. First one is a 74-year-old gentleman, pseudophakic. After cataract surgery, the patient is still saying that, sir, I am having blurring. Usually in a corporate practice, they are sent to the glaucoma clinic, and we saw everything was normal. I just went ahead with the ocular Doppler, and then I got a call from the radiologist that some abnormal vessels are being seen here. So what to do? The radiologist told me that, okay, I am going ahead with the carotid Doppler, and in the carotid Doppler, you can see there is a 100% blockage of the internal carotid artery. So going back to the slide, so we are getting some aberrant vessels, and due to that, we are getting aberrant waveforms. So that is how we diagnose something different when we are doing an ocular Doppler. Case 2, similar patient, after doing a cataract surgery, there was a pressure of 24, referred to the glaucoma clinic, everything was almost okay. We went ahead with the ocular Doppler, and there was no detectable left short posterior ciliary arteries. Here again, there was the internal carotid artery, there was a plaque, and there was a blockage. Stenting was done, and post-stenting, when we did the ocular Doppler, we can get some flow in the short posterior ciliary arteries. So to the best of my knowledge, this is the first case where we have seen that there was post-vascular intervention, the patient had some flow in the SPCAs, but the problem is that the patient is having the same ocular complaints even after that. So what is the way ahead? We have to see how this technology goes ahead, and is there any drug or any intervention which we can do which can increase the ocular blood flow. Coming to the OCT angiography, it is also non-invasive, uses the principle of motion contrast. It calculates the vessel density, which is basically defined as the area occupied by the vessels divided by the total area. So we have radial peripapillary capillaries that are seen in the nerve fiber layer, and the superficial plexus that is seen in the ganglion layer. So the advantage of the OCTA over the FA is that we can see the capillaries better here as compared to a patient with where we do a FA. So we get a printout like this, where there is a vessel density map, heat map, and the various indices. So that is how we see the optic nerve head, radial peripapillary capillaries, and the macula superficial plexus. The optic nerve itself is not a very good indicator because of the variability of its structure, and the superficial big vessels, they basically have a shadowing effect over the deep vessels. So here is the OCT angiography providing us something more. So OCT angiography with the various studies, we have seen that they are basically not having the vessel density index lower in those patients where the OCT RNFL thinning is also there. But they are better in the patients where there is an advanced glaucoma, where VD index would be better as compared to OCT RNFL, because we know the floor effect is there. It has also been seen in few studies where there is a disc hemorrhage. It can tell if there is a progression. There also, as you can see in this picture, that there is a progression which is seen with the serial OCT scans. Before I end my presentation, we have identified a biomarker also, where there is in the beta peripapillary zone, there is a total devoid of any vessels, where we can say that yes, it can be a biomarker for the future progression of glaucoma. Here also the limitation is there is no normative data, and vessel density is significantly affected by the signal density. So better is the signal density, better is the vessel density. So take-home message is OCT angiography might be useful in the identifying glaucoma progression, and can be used as a biomarker for identifying future risk of progression. My last slide is circulation around the optic nerve head is still complex and might need more in-depth analysis, and both color Doppler imaging and OCT angiography cannot be used as a single modality of treatment. Thank you.
An excellent talk, Dr. Vineet, and I think this is the more upcoming part of glaucoma management, and maybe the audience will have many questions for you later on.
Thanks.
So now I call